So we got through that, right? The modality, blah, 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 blah. Okay. So, cool. Okay. I think that's what I got next. So did we have any questions from the other day? Nope. All right. So classification of receptors. As we're going to see here, there's several ways we can classify them. The first is based on their modality. When they say modality, does that mean anything to anybody? Like, it's the what information do they convey? So what are they monitoring? Okay. So we're going to have what are called like chemical receptors or chemoreceptors, thermoreceptors. Obviously, chemoreceptors are going to measure presence or absence of certain chemicals. Generally, they function to measure pH. So chemoreceptors measure pH. Thermoreceptors, obviously, they're measuring temperature changes. Mechanoreceptors are measuring some sort of, or picking up, detecting some sort of mechanical stimuli. Oftentimes that's stretch, okay? Something, the receptor gets stretched and it picks up on that. Photoreceptors pick up on light. And nociceptors, anybody know what nociceptors are? They deal with pain, okay? Presence or absence of pain, okay? So you could take any receptor based on what its modality is and throw it into one of those groups. You could take that same receptor and classify it based on its origin of the stimuli, basically inside the body, outside the body, in joints. They'll have different names. Some examples of those are interoreceptors, basically receptors giving us information about inside our body. Okay, maybe the pH inside somewhere. Maybe the pH in the stomach could be an interoreceptor. Proprioreceptors, those are receptors that are found in and around the muscles and joints, and they're giving us information about whether the muscles stretch or contracted, which tells us what kind of position the joint is and where that appendage is in space. Okay, so they're the things that maybe are in your elbow that tells you where your hand and wrist are when you move them. Okay. Exteroreceptors, these stimuli are generally in the skin, designed to pick up information about the outside world. Is it hot outside? Is it raining? Is it cold? Is that wet? That type of stuff. That isn't information of something inside the body, it's something in your outside world that the receptor picks up on. Distribution of these. So we have what are called general sense receptors that are widely distributed. These types of receptors are found in the skin. They're found in the joints and the muscles. A lot of them concentrate in area where we want to get these general senses. Touch, feeling things. Your face, your hands, your feet have lots of these types of receptors, widely distributed throughout the body. You have touch receptors on your back, okay? They have little devices that have like little points, and they can separate them out, the distance between them, or bring them together. And it's called two-point touch, okay? And they can take those, put them really close together, and touch you with that on your hand, your face, your feet, and you can tell that there's 2 points, okay? They take that same thing, that same distance, and touch you on your back. It's going to feel like 1 point because the receptors are so spread out, it's only being picked up by, like, say, one receptor, okay? So to you, it feels like one device is touching you, not 2 different points, if that makes sense, okay? So how concentrated the receptors are, the more of them there are, the more input you get. Does that click for everybody? All right. Another type of sense or receptor are your special senses. These things are limited to your head, and they're the things that only these receptors pick up on. Vision, hearing, balance, smell, taste, okay? So going back to the general senses, touch. You can feel touch anywhere on your body. You feel it better on your hands and face and feet, but you can feel it everywhere. You can only taste in your mouth, on your tongue, okay? You can't put something on your hand and taste it through your hand, okay? So those are special senses. Pain, all right? Pain was, what type of receptor, what modality receptor did pain? Nociceptors, good, okay? And so Basically, all the things in the body can perceive pain. It's found in all the tissues except the brain. Now, it's found in the meninges, so you can still get pain in your head and around your brain, but the brain itself doesn't have nociceptors. And pain, while we don't like it, is generally a good thing. It's telling us something's wrong. Okay? If you sprained your ankle, the pain in your ankle is saying, get off your ankle, idiot, you've hurt your ankle. Okay? If you don't have that pain, you're going to do more damage. Okay? Take somebody that maybe has really bad type 2 diabetes, and they can't feel their feet anymore. Okay? Well, they could walk on things, cut their feet, walk on the hot pavement, burn their feet. All of those could lead to infection because they can't feel it. They have no idea. Okay? And that'll eventually do them in. So pain generally travels on fast pain fibers, and it's perceived, fast pain is perceived as usually sharp. Stabbing's another word that you might use for it, and it's very localized. You're very aware of exactly where it is, okay? So sharp stabbing pain that's localized. If you're lifting weights and you hurt your shoulder, generally if somebody walked up and said, what happened? Like, I hurt my shoulder and I hurt it right there. It's just killing me. That's fast pain fibers. You're really sure where it's at, okay? Over time, as that becomes more of a chronic thing, the same person says, well, where's your shoulder hurt? And now you're like, I don't know, it just like hurts all in around here. Now it's not very well localized. It's diffuse. It's spread out. That's more of a slow pain. Okay? Slow pain fibers travels in the unmyelinated fibers. We already know about those type Cs. Type C fibers, and it's perceived as a longer lasting, dull, achy, diffuse pain. Okay? The sharp pain was fast. It was like, there's a problem. You've got to stop right away. The slow pain is more of the chronic type thing. Okay? Pain, muscles, joints, bones, those things are more of a life or, could be life or death for you to fight off something or run away from. That's usually on fast pain fibers. Stomach aches, things on the inside of your body, it's a little bit more of a slower pain. I think we mentioned the difference between the fast and the slow. Somatic pain generally arises from the skin, muscles, joint. It's going to typically be fast pain if it's acute, if it just happened, and then over time it'll switch to more of the slow pain. Visceral pain inside the body. This is usually done due to some sort of chemical irritants, being cut off from oxygen or blood. Okay, if you cut the tissue off from blood, it's cutting it off from oxygen. It's said to then be ischemic, and that'll usually result in some sort of pain. Stretching, overstretching of internal organs can lead to this visceral pain. Visceral pain tends to be more on a slow pain fiber, type C. Okay. Now, some of the chemicals that are released that cause pain include bradykinin, prostaglandins, serotonin, potassium ions. Depending on the receptor, these different things can all be perceived as pain. Bradykinin, and I could be wrong, I feel like I'm losing my mind some days, I can't remember things, but I'm pretty sure bradykinin is what like a scorpion injects into your skin when he stings you, or it stings you, he or she. Okay, so if anybody been stung by a scorpion, those hurt really bad. That's that bradykinin. That chemical will cause a pain feeling. Okay, so I encourage you to go out and do it. It's a lot of fun. You guys have all lived out here. Nobody's been stung.
3 or 4 times.
Okay, it hurts like hell, doesn't it? No?
But it affects, from what I understand, how it works is similar to allergies. So everybody, certain people don't have
Okay.
allergic reactions. So I get stung, I'll have a little sharp pain right where it happened. That's it.
That's it.
My wife
Okay.
gets stung. We go to the ER because her eyes start to,
Yeah.
after a while. It does something, it blocks some neurotransmitter.
Yeah. Really messes her up.
Losing control, or it gets real numb.
But yeah,
That's why they get worried about kids and elderly.
right. When I've been stung, the pain is just it's like the whitest, hottest pain right where the thing stings you. You can't even see where the little stinger stung you. And then over time, in the next 12 hours, it just moves up wherever you got stung, whether it's your arm or your leg. Pretty soon it'll be all the way up into your shoulder, will be throbbing. And then it goes away. Little bastards hide in my house and sting me all the time. Even made me drop a whole bottle of vodka one day. Shit, it was on then. I found that little guy and I stomped his little head. That's how I get through life. All right, so which of the following is not an option when classifying a receptor by its modality? So which of these terms is not referring to a receptor based on its modality? Number one, proprioceptor. Nociceptor was pain, the chemoreceptor was pH, mechanoreceptor is some sort of mechanical stimuli. Proprioceptor was basically, it's telling you it's in a joint. It's not so much a modality. Somatic reflexes. Okay. Have we mentioned what a reflex is before yet? No? Okay, maybe that was 202. So when you think of a reflex, how would you describe a reflex to somebody? What would you say that, like, this reflex, that reflex, what do they all have in common? It's an automatic response, okay? So it's automatic, would you say then it's involuntary, okay? You reacted however you reacted or whatever happened, and you didn't really think that through, it just happened on its own. So reflexes are involuntary. Now, generally, do you think they're predictable? Like if you do this, this will happen? Yeah. When they're doing the patellar reflex and they hit your patellar ligament with the reflex hammer, they know your leg's going to kick up. That's why they don't sit right in front of you when they do it. Okay? So they're predictable. They're involuntary. I think they're quick. They happen very quickly. So quick, involuntary, stereotyped. Stereotype's a way of saying predictable. You knew what was going to happen. I mean, it's a reflex if you jump out and scare somebody and they scream. You know, sometimes they've startled them, they've jumped, they've screamed, probably some swear word, and then they've punched you. That could be all reflexive. My favorite are some of those videos online where somebody's scaring somebody and they jump out and the person just clocks them off a reflex. The joke's on them. Okay? So 5 components of a somatic reflex arc. This is very simple. Okay? So first, we have to have some sort of stimulation, right? We stimulate some receptors. If it's the patellar knee-jerk reflex, the stimulus is striking that patellar ligament with the hammer, and that puts a stretch through the quadriceps muscle. Okay? That stretch is the stimulus that will get the muscle then to contract. If you jump out and startle somebody, or you walk up behind somebody and you got like some noisemaker like an air horn, and they jump, that was the stimulus, that sound. Okay? That stimulus is going to get carried by a sensory afferent fiber, okay, back to the central nervous system where it'll synapse on what? What neurons are in the central nervous system that process this, integrate it? Again with an I. Interneurons. So that goes back to the interneurons. The interneurons integrate that information, process it. They send the response back out on efferent fibers, motor fibers. Since it's a somatic reflex, the effector is going to be skeletal muscle, and the reaction, whatever it is, takes place. The knee-jerk reflex, the quadriceps contract. Okay? One semester when I'm ready to retire or be fired, I'll come in and I'll put like a tack in somebody's chair. And that'll be our demonstration of a reflex. As you sit down and that tack stabs you in the butt and you jump up out of your chair and start swearing, that'll be us a good example. We'll have a good visual. Okay? Muscle spindle is a type of receptor, and this picture is showing us a muscle spindle. Okay? So we see the striation, so we know we're looking at skeletal muscle fibers, okay? And it has this spindle wrapped around it. And it doesn't take a whole lot to realize as this muscle is stretched or even contracted, it's going to change the shape of that coil around it, that spindle. That changing of its shape is one of those, it's proprioceptive information that gets sent back and your central nervous system processes it without you having to worry about it. But all that information gets integrated by the brain, and let's say these muscles, they look like they're coming off maybe the femur there. They'll give you an idea of where your leg or your hip is in space based on all that information. So a muscle spindle is a sensory receptor, and it will monitor the length of the skeletal muscle. Is it being stretched? Is it contracting? Either way, that tells the brain what's happening at that joint that the muscle attaches to. So proprioceptors are a type of stretch receptor. They often measure the stretching of the muscle. They'll respond to prolonged stretch, but they give you that what's called joint position sense. Sometimes people train to get these proprioceptors working really quickly. Okay? Gymnasts. Okay, those little gymnasts that are doing those flips on that little 4-inch beam, their proprioceptors are phenomenal. That's how they can do all that stuff and balance, while the rest of us would probably impale ourselves on the thing trying to just walk on it. Okay? Their brain's processing lots more information, lots quicker, and the quicker it is, if they start to lean one way or the other, that gets sent to the brain, reflexes go to certain muscles, get them to contract so that they right the ship, so to speak, and don't fall down. Okay? Does that make sense? Everybody, we can see kind of how that spindle would work. Stretching this deforms it, and these are all throughout the muscles. So this is lots of information your body's processing at any given time. And you can increase how well these work by doing, you see somebody doing like wobble boards. That's what they're doing. They're increasing how fast these things send the signals back and forth. Okay? Because most of us don't have good proprioceptors. To stand, I'll give you just an example. To stand upright takes your eyes, semicircular canals in your ears, and your proprioceptors. 2 out of those 3 got to be working pretty well for you to stand up and have good balance. Okay? That's one of the reasons Johnny Law pulls you over and he had you doing some sobriety checks and he has you close your eyes and standing up, because your brain and all that's already messed up. You're closing your eyes, so now it's proprioceptors, semicircular canals. Semicircular canals are under the influence, and you're swaying. You can't stop swaying. He knows that you're going to get in trouble. But like I said, those are supposed to be working. Take one of them out of the equation, and you can check the other ones. I've sprained my ankles too many times playing basketball. If I stand on one leg, I don't know if you can see it, my joints don't know where the F they are, okay? They're shaking like I'm scared to death up here because the signals are going back and forth saying, oh, don't let him fall this way, don't let him fall this way. The muscles are working. If I was to do these things over and over again, I would get better at them, but that would require work and effort, and I'm not willing to put that in. Plus, I'm old and I don't move anymore. So anyway, when you see people doing one-legged stands or wobble board stuff at the gym, uneven surfaces, that's what they're trying to build up, is that it's more of a balance thing. Think of how many sports you'd play, whether it's wrestling, basketball, things, just being on balance makes a huge difference. Okay. Stretch reflex, it's the one we've been talking about, the patellar knee jerk. You send a little stretch through the muscle, and the muscle automatically contracts. Okay? This is to help you maintain equilibrium, posture, that type of thing. So, and a lot of you guys won't be able to see it, but if I was doing something, you've all probably sprained an ankle at some point, right? You kind of roll your ankle in. So if I was doing something and I started to do this, that's going to stretch everything going up the side of my leg. If those muscles contract fast enough, I won't get my fat ass too far out over my ankle and sprain it. I will kind of gather myself again. So that stretch was the stimulus, and if the proprioceptors were quick enough, it's less likely that I'm going to hurt myself. And this knee jerk reflex, when you sit at the doctor's office and they take the reflex hammer and they hit you on the ligament, that little stretch causes a stretch in the quadriceps, because this quadriceps come off the top of the thigh attached to that tendon. So just imagine on a big stretch, if I took that tendon and I could pull it this way, it would pull the quads, right? Just that little bit of stretch causes those to contract. And it sends inhibitory signals to the antagonist, which are the hamstrings, to relax so that the leg kicks. Okay? And all that's done is basically stimulus, afferent fibers to the interneurons of the spinal cord. It doesn't even have to go to the brain yet. Sends the efferent back out for the muscle to contract. Okay. So sudden muscle stretch causes the reflex. You've noticed that if you've ever had somebody stretch you, okay? Maybe hamstring stretches. They're laying on their back, one leg straight, you grab the other leg, you start to take it up, and what do you feel them doing? Pushing back against you. They're not trying to, they're wanting you to stretch them out if that's what you're doing. But that stretch in those muscles causes those muscles to want to fight back. So you have to kind of wait through that, wait for them to relax. You can do some other things to kind of get past that, but that's what's happening there. Take muscles of the head and neck are the same way. Take somebody's head and push it down, and they'll just immediately jerk it up. Okay. So knee-jerk patellar reflex is one example of this stretch reflex. The signals that go to the antagonist, the hamstrings, is called reciprocal inhibition. And this prevents the muscles, the hamstrings in this case, from working against the quadriceps. Now, the thing with these reflexes is your brain can kind of override them. If you go to the doctor's office and they're doing this as part of a baseline neurological exam, sometimes they'll hit your knee and nothing happens. Sometimes if you're like me and you don't like them hitting your knee, you'll just make your foot kick, and they know that wasn't quite normal either. So they'll distract you. They'll give you some task to do. Sometimes it's called, they'll have to say, put your hands together and pull them apart, or pinch, snap your fingers, or whatever, just to distract your brain, and then they'll see the reflex. And they'll do both sides to compare them to see that they should be, you kick the legs similarly on both sides. Okay. Another type of reflex is called the Golgi tendon reflex. So the stretch reflex was on the muscle fibers. Golgi tendons, these receptors are in the tendons. They come off the muscles, tendons attach muscle to bone. Thank you. Okay. These are another type of proprioreceptor. And they're located, like I said, in the tendon. Now, what triggers them is excessive stretch or tension on the tendon. Okay. The stretch reflex, the one we just did, if we stretch the muscle contracts. Okay. This is more from a long-term stretch in a tendon. It'll cause the muscle to relax. Okay. So it's a body's way of trying to protect itself. So if I'm at the gym and I'm doing curls, doing preacher curls, probably 200 pounds, just getting warmed up, and I'm curling it up, and for whatever reason I'm holding it here like a dumbass, and this tendon that my biceps attaches to my lower arm starts to get too much tension in it, where the body feels like it's going to rupture or fail. It'll tell my biceps to relax and let go, basically, so it goes down. I'll drop the weight, I'll let go of the weight, I'll put the weight down, as to not tear the tendon. That's what a Golgi tendon reflex is going to do. So it's going to inhibit the motor neuron, in that analogy it was the biceps, and contraction is decreased in a way to try to protect the muscle. Now, this Golgi tendon reflex also happens when when you have muscles that have multiple heads, don't contract evenly. Okay? Commonly, this will happen in the gastrocs. Gastroc left and right side, and then there's two heads, right? And sometimes you look at people's calves, and like the inside head's big and the outside isn't, or the outside is, if it's uneven, think of that Achilles tendon going down. I got one muscle here that's pulling really hard and really strong, and then one little soft, lazy one over here. That's going to create an uneven shear in the tendon. One side's going to pull a little harder than the other side. That could damage the tendon. So the body will shut down the strong side to even it out, to make it only as strong as the weaker calf. Okay, so functionally, it's not so good for them. The body will make both sides weak to even it out and try to protect the Achilles tendon from rupturing. So you get kind of the difference between a stretch reflex and a Golgi tendon reflex. They're both receptors, though. They're both giving us information about the muscles and the joints. They're both types of proprioreceptors. that takes us into the autonomic nervous system. The autonomic nervous system, was that a visceral division, a somatic division? Visceral. All right. Was it sensory or motor? Motor. So visceral motor. Okay. And autonomic, I said for the time being, think of it as like automatic. This is the nervous system that's doing a lot of homeostatic type things that you don't have to consciously think about to make it happen. Okay? So it's a visceral motor division. So its effectors, would skeletal muscle be an effector for this? No. Okay? Skeletal muscles we know are voluntary. We control skeletal muscles. Visceral motor division, automatic things that are happening, autonomic nervous system things are going to be involuntary structure. So that's going to be what type of muscle? Cardiac muscle, smooth muscle, glands, those types of things. Good. So controls glands, cardiac, and smooth muscle. These things are done, you don't have to think about it, so it says regulates unconscious processes. Okay. You have another, just as an FYI, you have another governing division that controls things that happen automatically in the body to maintain homeostasis, and that's the endocrine system. It uses hormones to do that. So the autonomic nervous system and the endocrine system kind of handle all those involuntary, unconscious processes. And they're functioning to try to maintain that stable internal environment that we know as homeostasis. Okay? Does it automatically. All right. So we have also what are called visceral reflexes. It's really the same damn thing as a somatic reflex, except the end result. The end result on a somatic reflex, the effector was skeletal muscle. A visceral reflex, the effector is going to be anything but skeletal muscle. But it's still going to require a stimulus. It's still going to take the information back into the central nervous system. It's going to process it. It's going to send out its signals on an afferent. The afferent happens to be visceral motor division, which we know as the autonomic nervous system. Okay? So the receptors detect some kind of internal stimuli. Could be that ischemia, could be a temperature change, some sort of chemical. That's the stimulus. It's carried on the afferent neuron. Synapses on the interneurons in the central nervous system. And then the next step would be the efferent neurons, right? And these are going to be visceral efferents, so we know that's the autonomic nervous system. Carried motor signals to the effectors. This is the autonomic nervous system. Okay? The effectors then would be what you just told me a second ago, cardiac muscle, smooth muscle, glands. Now, with these things, cardiac muscle, for instance, cardiac muscle has its ability to create its own action potentials. Okay? In skeletal muscle, the action potential is what led the skeletal muscle to contract, right? So in cardiac muscle, it generates its own action potentials and tells itself to contract. The nervous system isn't telling it to contract. It contracts on its own. The nervous system isn't the cause for your heart to beat, but it modifies it. It can speed it up and slow it down. That's how somebody can be brain dead. Their brain waves are totally gone. They're gone, but their heart's still beating because the heart's telling it to beat. Okay, does that make sense? Okay. So the autonomic nervous system modifies the effector activities, not generally the cause of it, because smooth muscle will also generate its own action potentials. So you could, reach in and pull the heart out of a chicken and it'll beat in your hand for a little bit, that type of thing. So that's your homework. Divisions of the autonomic nervous system. I'm going to guess maybe somewhere along the line you've heard of these two terms. There's two divisions. There's the parasympathetic and the sympathetic division. Okay? Sometimes these work against each other. Okay, sometimes they'll work together. So they might have cooperative effects, or they might work in contrast to each other. One tells it to do one thing, one tells it to do the other. Sometimes they innervate the same target organs at the same time. Okay? And when they do that, the kind of when we talked about like resting membrane potentials, the equilibrium, the sodium that's leaving or the potassium that's leaving equals the potassium going out. Well, sometimes these same target organs, there's a balance between the signals they're getting from the sympathetic nervous system and the signals they're getting from the parasympathetic nervous system, and they're getting a little bit all the time, and then that balance, what that normal is what we call autonomic tone. Okay? It's kind of the normal rate of activity from both parasympathetic, sympathetic nervous systems at the same time in the same target organ. Okay? So it's that balance between them. Now from there, things can still get modified because we change that balance. Maybe the sympathetic nervous system starts to fire a little more intently, or maybe the parasympathetic does, and then it changes what's going on there. The effect of each of these systems, parasympathetic and sympathetic, depend upon which neurotransmitter is being released. Okay, that makes sense. All right. The other factor that's going to be involved in that's not only which neurotransmitter is being released, but what else? What's the other thing that determines how that tissue is going to respond? The receptor. Okay. So what neurotransmitter is being released and what receptor is there for it? Okay, because we know acetylcholine, that's the most common one. We know it can be excitatory at times, and we know it can be inhibitory at times. It's the same acetylcholine, so the thing that had to change is the receptor on different organs. All right, so the sympathetic division's the first one up. This division prepares the body for physical activity. It's often called the fight or flight division. Okay. It is gearing up for you to fight something off or run away from it. Okay. So if I just told you that much, prepares the body for physical activity, it's called the fight or flight division. If I said, what do you think it would do to your heart rate? Increase it. How about your breathing? Increase it. So those are a couple easy ones. How about this is not that hard if you think through it. Blood glucose levels would increase it, right? The more glucose in the blood, the more energy we have, because we don't know. This might be a long fight or long flight or whatever. The only other one might be tricky. So fight or flight, what does it do to pupil size? Does it dilate the pupils or constrict the pupils? Dilates, okay? Dilates, lets in more light, lets you see a little better in the dark, okay? That's a tough one to necessarily know. So increases heart rate, blood pressure, airflow, blood glucose levels, prepares you to fight something off, UFC style, or run away from it, okay? Parasympathetic division has a calming effect on many body functions. It's sometimes called the rest and digest system. So the term here says assists in bodily maintenance. So that's a little bit of processing food through your GI tract, digestion, and then eliminating the wastes. Okay, so it's going to do with the things we just talked about the opposite that the sympathetic nervous system did. So heart rate's going to go down, blood pressure's going to go down, breathing's going to go down, blood glucose levels, you're going to go more into a storage mode where you're going to store glucose as glycogen. It's going to constrict the pupils, okay? Somatic nervous system versus the autonomic nervous system pathways. Here they're showing us a somatic efferent innervation. This little ball right there, that's supposed to be the soma or the cell body. So something came down the spinal cord, synapsed on this, and it went out the ventral root, ventral horn, out. It's a motor neuron. This neuron will generally span the distance from the spinal cord out to its effector. Okay? This effector being skeletal muscle, it releases acetylcholine as its neurotransmitter. Okay? Myelinated axons. Autonomic system, so I'm not really specifying sympathetic or parasympathetic, I'm saying both. We have that same neuron, or different, we have a neuron coming out of the spinal cord, not the same one. It'll come out, it'll go partway there, it will synapse on another neuron, so we have a preganglionic neuron and a postganglionic neuron. Oftentimes they hook up in a ganglion. The postganglionic neuron will then go and innervate the target organ. Okay? Now, the preganglionic neurons of the autonomic nervous system are myelinated. The postganglionic neurons are not. Okay? The preganglionic neuron releases acetylcholine onto the post. The postganglionic neuron might release acetylcholine or it might release norepinephrine. The target organ might have a couple different receptor choices for each one. Okay? So autonomic nervous system has two neurons that span the distance from the central nervous system to the effector. Its presynaptic neuron cell bodies in the central nervous system. Its synapse is on a postsynaptic neuron, oftentimes in a ganglion. And then the cell, that's where the cell body is, and then it goes the rest of the distance to the effector. Okay? Let's see here. So, if we have the sympathetic nervous system, all right, and we've got a preganglionic neuron, synapses on a post, okay, it's always going to use acetylcholine, all right, acetylcholine is going to be the neurotransmitter onto the post. And then the postganglionic neuron to its effector is going to use norepinephrine. Okay? If we have the parasympathetic, we've got the pre synapsing on the post. It's also going to use acetylcholine. And the post on its effector is going to use acetylcholine again. Okay, so pre on the post with the autonomic nervous system is always acetylcholine. What the postsynaptic neuron releases on its effector changes depending on if we're sympathetic or parasympathetic. Okay, and then we'll touch on the receptors here in a second. So sympathetic division. Oof, oh, this gets hairy. So origin of the preganglionic neuron. So where this, we did sympathetic, where this preganglionic neuron comes out is generally in the thoracic spinal cord. Okay? They'll say this thoracic spinal cord T1, which is the very top of the thoracic spine, to L2, so almost the midway point of the lumbar. So sometimes they call this the thoracolumbar division. They're doing that to tell you where the preganglionic neurons, where this originates from, where these signals originate from. Going down the spine on each side is what's called the sympathetic chain ganglia. Okay? So the word they're going to use here is paravertebral, meaning on both sides of the vertebrae. There's a chain ganglia going down the left side, there's a chain ganglia going down the right side. For the sympathetic division, the preganglionic neuron is going to come out of that spinal cord level. It's riding along with that spinal nerve, and it's going to exit and go into this chain ganglia. Okay? Ganglia is where we've said we find cell bodies, right? Somas, neuron cell bodies. So this is a good place for them to have their synapse. All right? Located the chain ganglia, so what they're wanting to tell you is even though the preganglionic fibers only come out T1 to L2, so let's say it's a section about this big, The chain ganglia runs all the way from the foramen magnum down to almost the sacrum, okay? So it runs all the way down all spinal regions. Pathways of the preganglionic fibers. So they're going to exit somewhere between T1 and L2. They can enter that chain ganglia and they can synapse on the postganglionic neuron right there. Okay? That's one option. So it's almost like they're going down the highway. They get off on the exit ramp, synapse, and then they're going to get right back on the entrance ramp, back on that highway and follow it to wherever it was going. Okay? That's one option. They can enter the chain ganglia, travel higher or lower segments, and synapse there. Okay? Now, we got a picture coming up which will help, but generally nerves come off the spinal cord and they go straight lateral. Okay? Sometimes they go lateral and they start to work their way down the body a little bit. Very seldom do nerves come out and go upward. Okay? So to have sympathetic innervation, I'll give you an idea. T1 is below your neck, right? We know your neck region innervates your arm, right? Maybe even a little bit of your head and face. So if we don't have preganglionic neurons coming out in the neck, how do we innervate anything from our arms or above? This is how we do it. It comes in, it gets in the sympathetic chain ganglia. Say it comes out right here, T1 or 2 comes out. It's going to take an elevator up in this sympathetic chain ganglia, synapse there, and then jump off on whatever nerve was coming out at that level, hitch a ride, and go to wherever, give us our sympathetic innervation that way. Hopefully between that and the picture, it'll become a little more clear. The third option is it can get off, pass right through the chain ganglion without synapsing, and travel to a different ganglion somewhere else. They'll call it collateral ganglia. Okay? Oftentimes this happens in the lower aspect of the body, and they'll ride on what are called the splanchnic nerves to different areas. The third one there isn't as important to us. Coming in, synapsing, going right back out is a very common one, as is going up or down in the chain ganglia and synapsing, and then following those nerves out. Each postganglionic cell receives synapses from multiple preganglionic cells. Okay, so that hasn't changed. We knew that. That's how we process all this information. They're all the pre's are getting to vote, telling the post what to do or what not to do. So here's kind of the hairy picture. All right? Don't let all the things on there overwhelm you. We've got our brain. We've got our spinal cord. Okay? It's going down to L what in adults? In adults? Like L1 or L2, I'd let you get away with that. So maybe L1 in adults, L3 in children. So anyway, that's where it goes. Okay? Green is supposed to represent the cervical spine, blue the thoracic spine, red the lumbar spine. So as you can see, it's all thoracic spine and just a little bit of the lumbar. So that's why they call it thoracolumbar. Down each side of it here in yellow, this is the sympathetic chain ganglia on each side. So the preganglionic neurons for the sympathetic nervous system come out of the spine in this area. Okay? They come out, they go into the chain ganglia. Okay? They get off on what's called a white ramus. Think of it as just an exit ramp. It goes right into this chain ganglia because this nerve was going somewhere. Okay? It was going past here. They get off the ramp on a white communicating ramus, a white branch. They synapse. They come right back onto that nerve, hitch a ride back on there with a gray communicating ramus, and then go to wherever that was going. So here, we're somewhere in the middle thoracic spine. It comes off, synapses, and then goes out here to innervate some internal organs, okay, the liver, the stomach, whatever. It can go into this chain ganglia and go up and synapse on the cervical chain ganglia that's up here in the cervical region. Hop out of there and jump on one of the nerves that was coming by here in the first place and go on up to the eye, okay, to do the pupil. And it's going to do what to the pupil? Dilate it or constrict it? Dilate it, okay? Otherwise, it wouldn't have any way of getting up there because these nerves come off and, like I said, they kind of work their way laterally and down. Okay? So fight or flight is the way they describe it. Thoracolumbar tells you where its preganglionics go, and the options of what it does is jumps into this, sympathetic chain ganglia that's running right next to the spine. Okay? So here's another question, or here's another fact, not a question. The preganglionics are very short in the sympathetic nervous system. It's a very short trip for them from the spine to this paravertebral sympathetic chain ganglia that's running right next to it. So when it synapses in there, then the postganglionic neuron is much longer. It goes the rest of the distance. Okay? In this case, to the eye, that's kind of a long ways. Okay? So sympathetic nervous system has short preganglionic neurons, long postganglionic neurons. Okay? Obviously, if I'm telling you that, then we can assume that the parasympathetic is either going to be exactly like it or totally opposite. Okay? Otherwise, we wouldn't give a shit. So here's what we were talking about a second ago. They've broken it down into one spinal cord level. We got our dorsal root and our ventral root, and they come together as a spinal nerve. It's going off to wherever this spinal nerve was going. Okay? But the sympathetic fibers exit on this white ramus, goes into the sympathetic chain ganglion, and here it synapses. Then it comes back out on a gray ramus, right back on that same road it was on, and follows it to wherever it's going. Gets close, might hop off. Okay? They kind of run together oftentimes. So that's option one. Option two, it does the same thing. It gets off on a white ramus, comes into the sympathetic chain ganglia. This time it went upward. Synapsed on the level above. The gray ramus takes it out onto this spinal nerve, and it follows it out where it was going. The third, that wasn't as big a deal for us, it comes off, it goes right through, doesn't do anything, and then finds a different ganglion somewhere else and does its synapsing there. Okay? Does that make sense for us, kind of what's happening? Somewhat, anyway? Okay. So that's the sympathetic. Sure. Could go either up or down. Oftentimes, and this won't matter. I'm giving it. You can put it in your brain, and then I won't ask you on the test. But between T1 and L2, if it comes off in the T1 or 2 area, more than likely it's going to synapse or it's going to go up, because we need to get those up here. It's not going to take one off of L2 and have it go all the way up the chain ganglia. Does that make sense? So the ones lower, when it comes out L2, they're not going to go up. They're going to tend to go down to innervate the things below her. Okay? All right, parasympathetic division. The origin of the preganglionic fibers there come out of the cranium, the head, or the sacral area. So they call it the cranial sacral division. We already called it the rest and digest. And so the origin of the preganglionic fibers are the pons and medulla oblongata. So that's basically brainstem. And they like to run along with the cranial nerves, which we haven't talked about yet. CN represents cranial nerve. Nuclei means their cell bodies. Or, so those are up in the head, or they run with spinal cord segments S2 through S4. So the nerves coming out of those sacral foramina at the level of S2 through S4. That's why cranial sacral division. So in the middle, in that thoracolumbar area, they ain't got anything. Okay? They're up high and coming off low, the two areas. Pathways for the preganglionic fibers. In the upper portion, they like to run along with cranial nerves 3, 7, 9, and 10. Once again, you're just writing down numbers at this point. That doesn't mean anything to us, but it will. Okay? They innervate the cardiac, pulmonary, esophageal, abdominal aortic plexuses. These are nerve networks. We'll just call it nerve networks. And then arising off the sacral spinal cord, these branches will run with these pelvic splanchnic nerves to the inferior hypogastric plexus. Those are some of the lower GI plexuses that they might get involved with. Now, sympathetic division, we said, had short pre's. They go into the sympathetic chain ganglia, and a long post from the sympathetic chain ganglia to wherever the effector is. Okay? Parasympathetics are the opposite. Okay? They have very long preganglionic neurons because the ganglion in which they synapse, the terminal ganglia, the end ganglia where they have the synapse, the pre on the post, is generally in or right near the target organ. So the preganglionic neuron goes almost the whole distance, and then we have a very short postganglionic neuron. Okay? And so that's what it's telling us there. Very long preganglionic neurons and short postganglionic neurons. Okay. So we got a picture coming up of this cranial sacral division. So here we're back to the spine. Okay, cervical region, thoracic region, lumbar. Basically the same picture, but now they're showing us the origin of the preganglionics for the parasympathetic division. And they're all coming off the brain or the brainstem. They're all riding along cranial nerves 3, 7, 9, and 10. Okay? 10, the way they number the cranial nerves, usually the further down the brain or brainstem they come off. So 10 is going to take a lot of the innervation. 10 is going to, it's called the vagus nerve. It's going to innervate the heart, the lungs, the GI. Okay? Cranial nerve turns very important for parasympathetic innervation. Or it comes off of here, off the end of the spinal cord, the medullary cone. It comes off there, it runs down, part of that cauda equina, runs through the sacral canal and comes out the sacral foramina. Okay? And then it goes to down here, like that's uterus, ovaries, male naughty bits, bladder, all right, that type of stuff. All right. None of the parasympathetic comes off in the cervical or thoracic spine. Okay. Cranial sacral division. All right. And then they're going to come off. It's going to go almost all the way to the target. There's going to be some ganglion nearby that it's going to synapse there and have a very short postganglionic neuron. Some organs are almost the synapse is right on the organ itself. The little ganglion that it synapses is right on the organ itself. So, based on where the preganglionic fibers originate for the parasympathetic division, we could call it the what? So we've had two names for each of these systems, right? Or the divisions. But look at the question. Is it asking like that based on what it does, we would call it this, or it's based on the origin of the preganglionic neuron? So what's the best answer? 2 is telling you what it does, right? It's wanting to know where the preganglionic neurons came off. They come off of the head and the sacrum, so that's the cranial sacral division. Okay? All right, so neurotransmitters and receptors for the autonomic nervous system. The neurotransmitter released and type of receptor on the target determines what effect we're going to get. Is it going to be excitatory? Is it going to be inhibitory? Okay. Another thing to know, sympathetic nervous system, its neurotransmitter it releases is norepinephrine. Norepinephrine has the ability to get into the bloodstream. And now a chemical messenger floating in the bloodstream is technically a hormone, so it can have hormone-like effects, and it'll stay in our system longer. Okay? And there's some other reasons for that as well, but sympathetic division based on what it does. Was that the rest and digest or fight or flight? Fight or flight, okay? So, when you trigger your sympathetic nervous system, okay, something's scared you. Or something's amped you up. Maybe you're female, you've come home and somebody's broken into your house. Or you're laying in bed and you hear somebody break into your house and that scares you, okay? Whatever it is. Maybe you had a dream that scared you and you wake up and your husband, boyfriend, significant other, guy passing through, whatever, he says, just relax, calm down. What can't you do? You can't calm down. Your heart rate's up. because you had this sympathetic response. That norepinephrine is now in your bloodstream, and it's going to take a while for your liver and kidney to get it out of there. You're going to be amped up for a while. Okay? Guys, the same thing. Hopefully none of you are out there getting in fights, but if you get in a fight with somebody, can you just calm down after that? Win, lose, draw, whatever? No, you're jacked up. Okay? Ready to knock some other fool out. All right? Anybody else want some? All right? That's because it has kind of these hormone-like effects. Now, neurotransmitters, let's start here with the parasympathetic. We have two types of neurotransmitters with the parasympathetic. We have a nicotinic receptor and we have a muscarinic receptor. Okay? When acetylcholine binds with a nicotinic receptor, it's excitatory. When acetylcholine binds with a muscarinic receptor, it's inhibitory. Okay? So remember how we said acetylcholine might have different responses? It depends on what type of receptor the tissue had. Nicotinic, they named because nicotine can mimic the effects of acetylcholine. Okay? Now, this is going to come up on the next screen. For our class, okay, this is the way we're going to do it. Muscarinic's inhibitory, nicotinic's excitatory. There are some exceptions, okay? I want you to know in your own mind there's some exceptions, but for us, we're going to pretend there isn't. If you go far enough in your education that you need to learn about the subclasses of receptors, you'll learn it at that point, okay? I just don't want me not to have told you that maybe you're in some sort of pathophysiology class or whatever, and you raise your hand and you're like, well, no, Sinner said, nicotinic's always excitatory. I want you to remember to say, yeah, I think he said there was exceptions, okay? Now, for the sympathetic, the type of receptors for norepinephrine, we have an alpha, can't spell it, and a beta receptor, okay? Alpha is excitatory, beta is inhibitory, okay? Once again, same thing. For us, that's what we're going to go with. If you get a question, you're going to assume the alpha is excitatory, the beta is inhibitory. But you know in the back of your mind, there's subclasses for these, and that's not always true, okay? Response, blah, 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 blah. And so this picture is kind of going through that. We're using acetylcholine here, we're using acetylcholine here. Presynaptic neurons, acetylcholine. So, if that's the case, to see how you guys are doing here, make sure everybody can see it. What type of receptor to acetylcholine does the postsynaptic neuron have in the sympathetic division? You got two choices. Nobody's feeling brave? If this neuron synapsed on this one and told it to fire, then it was excitatory or inhibitory? Excitatory, so the receptor has to be nicotinic. So this is a nicotinic receptor. Down here, is it a nicotinic receptor? It's a nicotinic receptor as well, because this is excitatory. This is excitatory. This presynaptic neuron's telling the post to fire. This is telling the post to fire, okay? So that's what they're showing us here. Acetylcholine crosses, tells this one to fire. Acetylcholine crosses, tells this one to fire. They're showing us the length of the pres with the lengths of the posts. And then what neurotransmitter the post releases. It releases acetylcholine norepinephrine, and it's going to have these alpha or beta receptors. Over here, it's going to release acetylcholine, and we're going to have a muscarinic or nicotinic receptor. Okay? So, kind of the same thing we just went over, but now you got a slide for it. Acetylcholine binds to two classes of receptors. Nicotinic receptors. Nicotinic receptors occur on all autonomic nervous system postganglionic neurons. That's what I just put right here. Where else have we seen that we're going to have a nicotinic receptor? Last unit. Nicotinic receptors are going to be found at all neuromuscular junctions because we used acetylcholine and it was excitatory. Okay? Nicotinic receptors are excitatory when acetylcholine binding occurs. Okay? Muscarinic receptors occur on all glands, smooth muscle, and cardiac muscle that receive cholinergic innervation because acetylcholine binding to them tends to be inhibitory. Okay? Now, for us, that's what we're stopping with. Muscarinic is going to be inhibitory. And then this is just our little thing to put in the back of our mind so we don't embarrass ourselves in some other class someday. It can be excitatory sometimes because we have some subclasses of these muscarinic receptors. Okay? Like I said, I doubt you're going to get into those subclasses very often. Depending on, if you're going into medicine, you would. You might even get into some of those in pharmacy, but otherwise probably not so much. If you get to that point, you can learn them there. My goal is to teach you about 80% of the stuff, get it so you've got it pretty good and move along. Okay? Adrenergic receptors for norepinephrine. Norepinephrine binds two classes of receptors. We've got an alpha adrenergic receptor. Norepinephrine we're going to go with is excitatory, but in the real world it can also be inhibitory. Beta adrenergic receptors, norepinephrine, once again can be excitatory or inhibitory. And if we remember right, acetylcholine opened sodium-gated channels, right, when it was excitatory. Norepinephrine, used as a neurotransmitter, worked by the secondary messenger system, the cyclic AMP, which we've gone over. Oops. Okay? So for us, we're going to say the alpha is excitatory, the beta is inhibitory. There are very few subclasses for the parasympathetic. There are more subclasses for this norepinephrine. Okay? So there's alpha 1, alpha 2, beta 1, beta 2, and they all respond differently. So this absolute of saying this is a bigger reach than this, okay? You guys still doing all right? Hanging in there? True or false, in the sympathetic nervous system, a presynaptic neuron releases norepinephrine onto the post?
False.
That is false. Good. Good. It releases what? Acetylcholine. Okay, good. All right, so most target organs, most tissues, have dual innervation, meaning the sympathetic nervous system innervates it, the parasympathetic nervous system innervates it. And sometimes, because of this, they'll have antagonistic effects. They'll work opposite each other. Sometimes that's through dual innervation of the same effector cells. Okay, so maybe the heart, they're both synapsing on cardiac muscle. Okay? They both synapse on cardiac muscle, but one of them synapsing on the cardiac muscle is going to cause it to beat faster. The other is going to cause the cardiac muscle to beat slower. That's an antagonistic effect. They're innervating the same structure, the same cardiac myocyte. Sometimes they can work opposite each other to get an opposite effect, but they're actually innervating different cells. The pupil, the iris, is the example of that. The parasympathetic division synapses, its effector is called the pupillary constrictor muscle. It causes that muscle to contract, and the parasympathetic nervous system makes the pupil constrict. The muscle that dilates, it's a different muscle called the pupillary dilator, innervated by the sympathetic division. So now we get the opposite effect, but they're actually innervating different cells, okay, doing different things. We can have cooperative effects when the two divisions act on different effectors to produce a unified effect. Saliva, producing saliva in your mouth. There's two things you really produce. You produce mucus and you produce the saliva, okay, when your mouth waters, okay? So sometimes they both can be firing, and that'll produce that when your mouth is watering. You know, maybe for Easter you went somewhere and somebody was making some good food and your mouth starts watering. That can be both divisions working together, okay? Not all the time does that happen there, because sometimes if I was to bring one of you up here and make you do some sort of like public speaking that you dread doing, your mouth's going to dry up, right? You're not going to produce saliva, you're going to just produce mucus, and the mucus is going to absorb any water you have in your mouth, and you're going to get cotton mouth because you're scared shitless to come up there and do that, okay? And so that's, I'm just showing you that the mouth secretions have a couple different innervations. They can work together or they may not. Both divisions do not generally innervate the organ equally. Some, they're often a little predominant to parasympathetic or they're predominant to sympathetic. If, however, we have an organ that doesn't have one, it's either going to be sympathetic or it's going to be innervated by parasympathetic, but it can't be by both. What system do you think would be the one they would have? Okay, they're either going to have sympathetic division or they're going to have the parasympathetic innervation. Which one would they have? Which one would you think in your mind? Think about it. It has to come down to which one might be more important. What was the question? You guys scare the shit out of me. So for the third, I appreciate you asking. I'm just giving you grief, sort of. For the third time, if some organ or tissue is going to only have sympathetic innervation or parasympathetic innervation, which one would it have? Which one's more important? Okay, so he's thinking sympathetic. We all agreeing with him? We're going to just follow him blindly. He's right. Okay, sympathetic, fight or flight. Think of fight or flight as that might be life or death. Okay? So that's the one they're going to have. If they don't have both, they'll have sympathetic. Okay? Oh, I don't care about this. That's the pupillary dilating, constricting, blah, blah, blah. So without dual innervation, sympathetic fibers only will be what they have. And there are structures that only have sympathetic fibers. Sweat glands, erector pili, and many blood vessels. Okay? Blood vessels we haven't got to have, we're running. We're good. We'll stop there. We'll pick up with this slide.